What is the nature of the relationship between celiac disease and HLA? Thank you, Nina.
Good afternoon, Chairman, ladies and gentlemen. Many thanks to Coeliac UK for inviting me to present our work. We've explored the association between HLA-DQ genotype and clinical and pathological presentation of celiac disease. As we know, celiac disease is most likely to have a multifactorial etiology with complex interactions between genetic factors and environmental factors. In addition to the contribution of non-HLA genes, HLA is likely to be a necessary but not sufficient causal role for development of celiac disease. The importance of HLA genes in the etiology of celiac disease may be illustrated by the concordance rate of 30% amongst monozygotic twins, that the vast majority of celiacs carry DQ2, and in those DQ2 negative celiacs, they carry DQ8. And individuals who have a double dose of DQ2, i.e. DQ2 homozygotes, have a 5-fold increased risk of developing the condition in comparison to those individuals with a single copy of DQ2. We know that DQ2 and DQ8 have a central role in the pathogenesis of celiac disease. Deaminated gliadin peptides bind to DQ2 or DQ8 on the surface of the antigen-presenting cell. The DQ-bound gliadin is then presented to sensitize cytotoxic T cells with the resultant production of pro-inflammatory cytokines and the characteristic enteropathy. Chris Mulder and co-workers have observed that homozygosity for DQ2 is associated with the development of etal and refractory celiac disease, whereas Vader and co-workers observed that antigen-presenting cells that were DQ2 homozygous elicited far greater T-cell proliferation rates and had higher inflammatory cytokine concentrations, thereby raising the suggestion that the carriage of certain HLA genotype may influence the phenotype. There have been a number of case series and cross-sectional surveys that have attempted to explore the association between HLA genotype and phenotype of celiac disease, though they've been somewhat limited by their small sample size, the selection of children alone, the genotype characteristics, as well as the phenotype outcome selected. We therefore performed a population-based cohort study using a large contemporary cohort to explore the association between DQ genotype and clinical and pathological presentation of celiac disease. All adults, whether newly diagnosed or those with prevalent celiac disease, attending the dedicated celiac clinic at the Royal Hallamshire Hospital over a 4-year period, were identified and studied. HLA genotyping was performed using PCR sequence-specific primers. A celiac was said to be a homozygote for DQ2 if they had 2 copies of the DQ-B102 allele, i.e. a double dose of DQ2. A celiac was said to be a heterozygote if they had 1 copy of the DQ-B102 allele or a single dose of DQ2. Those celiacs not carrying DQ2 but having the DQ-B1, O3, O2 allele were said to be DQ8 carriers. Celiacs not carrying either DQ2 or DQ8 were carrying the DR5, DQ7 haplotype and were said to be DQ2 negative, DQ8 negative celiacs. At diagnosis of celiac disease, a number of variables were systematically collected, including the mode of presentation, laboratory tests such as hemotinic profile and liver chemistries, the Marsh grading of their duodenal biopsy, and celiac serology. Analysis of variance was used to compare the association between a continuous variable, such as the mean age at diagnosis of celiac disease, and the HLA genotype, whereas logistic regression was used to compare categorical variables, such as Marsh grading of the duodenal biopsy and the HLA genotype. There were 447 celiacs in our contemporary cohort at Sheffield. 94% of celiacs carried at least one copy of DQ2, and as you can see from this chart, the most prevalent DQ genotype was that of DQ2 heterozygosity. 24 of the 26 celiacs that were negative for DQ2 were carriers for DQ8. There were 2 celiacs that were negative for both DQ2 and DQ8 in the entire cohort. The proportion of females that were DQ2 homozygotes did not differ to the proportion of females that were heterozygous for DQ2 or those that were DQ8 carriers. Mean age at diagnosis was similar, whether there was a carriage of DQ2 or whether there was carriage of DQ8. Proportion of celiacs presenting with a childhood diagnosis of celiac disease was similar, whether there was a single copy of DQ2, a double copy of DQ2, or whether DQ8 was carried. Iron deficiency anemia and diarrhea were the most common modes of presentation of celiac disease. The proportion of celiacs presenting with anemia, with diarrhea, weight loss, malabsorption was similar, whether they were DQ2 homozygotes, heterozygotes, or were DQ8 carriers. This table illustrates some of the laboratory variables that were systematically collected at diagnosis. Mean hemoglobin was similar between the 3 genotypes. Mean ALT, which we've previously presented at a Celiac UK conference as reflective of more severe celiac disease, appeared higher in DQ8 negative and DQ2 negative DQ8 carriers, but this did not reach statistical significance. Hematinic profile, liver chemistries, cholesterol profile was similar with all the 3 different genotypes. 60% of the Sheffield cohort had subtotal or total villus atrophy at diagnosis of celiac disease. The DQ8 carriers appeared to have milder histological change, with 2/3 having partial villus atrophy or milder histological change. However, on looking at the data, according to the proportion of celiacs presenting with villus atrophy, there was a similar proportion of celiacs presenting with villus atrophy, whether they carried DQ2 or whether they carried DQ8. This table represents the celiac serology at diagnosis of celiac disease. 50% of DQ8 celiacs were positive for EMA at diagnosis, in comparison to 90% in the DQ2 celiacs. Similarly, the mean TTG titer was significantly lower in the DQ8 carriers in comparison to the DQ2 carriers at diagnosis. In conclusion, DQ2 heterozygosity is the most prevalent genotype seen in a contemporary cohort of celiac disease, and 94% of the cohort carry at least a copy of DQ2. The presence, the dosing of DQ2 is unable to predict the mode of presentation of celiac disease, the pathological presentation. However, the higher TTG titers and the higher EMA positivity in the DQ2 carriers may reflect greater B-cell responses, similar to the previous study showing greater T-cell responses in DQ2 carriers. As for the role of DQ genotyping, we believe on the basis of our work that this should be reserved for assessing risk of celiac disease in equivocal cases rather than predicting the course of celiac disease. Many thanks for your time.
Can I ask you a question here?
Of course.
Your data is at odds with a lot of what's published in the literature. Why do you think that? And do you think that if you had more patients with homozygote, you would actually have a different set of results?
I don't know whether this reflects the systematic collection of the data, in that you almost religiously follow up each of your celiacs in the dedicated celiac clinic, and it generates the broad spectrum of celiac disease, rather than in tertiary referral centres seeing the more severe cases, and that may skew the wide distribution of the DQ genotype prevalence. I think from the nature of the way we've collected the data, it's more reflective of what is underlying true.
Any other questions? Sarah? Yeah, please.
Were you surprised at how little influence the HLA seem to have on the expression of the disease?
Yeah, because it's central to the pathogenesis. So yes, but of what we can readily, tell the patient of, am I likely to present with anemia? Am I likely to have diarrhea? How severe will my biopsy show? These are sort of common questions that patients are likely to ask of what will happen to me, how bad is my disease? And all I can say, there's no obvious association with that is in patient-friendly terms. But we see from Chris Mulder's work of the association with refractory celiac disease and ETL. So I think further work is required in this area.
Nina, thank you very, very much.